All right. Okay, so let's continue where we left off yesterday. We were talking about tears, and this is a paper from 2014 where they actually followed tears over time to see what tears healed and what tears didn't heal of the menisci. And so what they found is that 95% of meniscocapsular junction tears healed spontaneously. So this is the really the red zone far out on the periphery. If it's separated, some people still like to go in and put sutures in maybe to stabilize it, make sure it heals properly. But this paper showed that the vast majority of those are going to heal on their own if you just give them time. Other locations, they found that only 22% healed. And the things that were associated with them healing was if they're less than 2 millimeters in width, not visualized on T2 weighted image, so no fluid in them. And if you can see bridging strands of low signal intensity through the tear, that portended to a better prognosis in terms of healing.
May I make a comment?
Of course.
The 95%, I'm not sure that that's right or wrong, but the ones that are repaired have to be separated like 3 millimeters from the capsule and the meniscus.
Okay.
So if there is a 3 millimeter, 2 millimeter separation, that requires fixation.
Good. Thank you, Jen. Excellent. Okay. Did Elior?
He's walking back from a procedure, so he's gonna log in
Okay,
as soon as he
fine.
gets.
That's fine. Okay. All right, then.
I lost the sound, John. I don't know why. Can you hear me?
Yeah, for some reason I accidentally turned the mic off.
I figured something like that.
Yeah. So Elior,
Your age is starting to show, John.
well, my age has been showing for a long time, John.
Oh, no, not as long as your friend here.
Hi, Elior. Elior, are you with us? Is your mic on? Unlike mine. Elior, we can't hear you if you're talking to us.
Yes, I'm here. Hi.
Great. Okay, good. Okay, and then if we look here, we can see some signal going into the free edge and a little bit of blunting of the free edge on the CT. So that just shows a meniscal tear on a CTR.
Okay, so
I'm
just stay
not sure we've done
all
one of
kind
these
of
in the last few
uniform
years.
dark.
What?
It's supposed to stay all dark, right?
All
What did you say?
dark. That's what his has done in the past.
No, I mean the meniscus. All that contrast.
Yeah,
That
this is
triangular piece right
abnormal,
there
and
is
that's abnormal.
okay.
And this is abnormal.
Okay.
Okay. So then we need to look at meniscal repairs. And these typically are non-degenerative tears. They're usually more acute tears. They're usually in young people. And the main differentiation is that the non-degenerative tears tend to have very black margins that are well defined, and the degenerative tears have ill-defined margins, and they've got abnormal increased signal intensity within them. So these would include acute buccal handle tears and acute peripheral tears. This is a nice article from JBJS back in 2006 on this topic. So what is a bucket handle tear? Well, it gets its name because this is a vertical longitudinal tear. within the meniscus, and that central fragment, along with the free edge, displaces into the notch of the knee. And this is what we're seeing here. And this is the handle. It looks like you could go in and grab it and pull it up. And this would be the bucket over here of a bucket handle tear. And on the MRI examination, here's what we can see. This is that central fragment. In this case, it's displaced into the notch of the knee and flipped so that the free edge is now pointing medially where it was pointing laterally. And this is the peripheral rim where there's been kind of an oblique tear, and you can see that it's smaller than it should be, involving the body. So that's the bucket handle, and then the bucket on the sagittal images. You see the so-called double posterior cruciate sign. We have the bucket handle here, the posterior cruciate ligament up there, and so it looks like you have two posterior cruciates, but obviously the bucket handle tear is really not in the same location as the PCL. Okay.
Okay, so we have
Now,
a
would
17-year-old.
anybody, excuse me, would anybody, if you can go a couple of slides back to the specimen, would anybody try to fix this? Obviously, it's been removed, but would anybody try to fix it?
I don't know. It's kind of devascularized, right? That portion. Kind of, yeah, we'd consider that the not
So
part of
you're
the bucket
saying
handle.
that this might not be very viable tissue?
Yeah.
Yeah, that's been there for a while, and it's all deformed, and even under the best of circumstances, in an acute situation, repair for this condition is difficult in terms of results. So you might be able to get 60-70% reasonable results, but overall, it's just not easy to fix because of what you see on the right side. It's all deformed.
Yeah, and I think the majority of bucket handle tears we see are more chronic. Patients have had them for some time. When we see them in the acute athlete within a day or two of it occurring, you've got much higher chance. In fact, the studies, I'll show some of the study results show that those do very well. But those that have been in or around for months, which many of those are, especially in the intermittent, not the real everyday athletes, but the intermittent athletes, they tend to get more deformed and degenerated and don't heal as well. Oops. Okay, all right. Roberto.
So we have a 17-year-old male with knee pain after trauma and locking the first week after MR. So we have two sagittals of the knee. Looking at the posterior horn of the medial meniscus, it looks like there's a complex tear.
Okay. Vertical and horizontal components. At this point, there was not locking. This is the time of the first MR.
Oh, gotcha.
A week later, it started locking.
Okay.
Okay. And then, so this is 712. We can see the complex tear right there, as you're saying. Here are the coronal images at that particular time. What do you see on the coronal images?
On the coronal images, looks like look, there's an oblique component. Yeah,
You
there.
can see, and this is peripheral. This is in the peripheral third. This is in the red zone, going right to the meniscocapsular insertion. So this would be a peripheral tear in this location. So both of these tears, which are common with bucket handle tear, okay, so this is a peripheral longitudinal tear, is in the red zone, where you would expect that there is a high likelihood, according to Kajowski's paper, at 95%, that this could heal as long as you let it heal. Very commonly when we see these, you'll see some bone edema here, typically in the subchondral bone of the tibial plateau. Often the articular cartilage will still be intact over this. This is probably some sort of injury to the trabecular bone, and it tends to be associated with meniscal tears. Still not fully understood exactly the pathophysiology of this bone edema. But it is interesting, back in 1986 or something like that, about the time that we were doing the first studies on MRI and meniscal tears, before we even published our first paper in 1989 or whenever it was, there was a paper that came out in the nuclear medicine literature showing that bone scans are 90% accurate in evaluating meniscal tears. And the recommendation was to stop using arthrography and start using bone scans to diagnose meniscal tears. The problem with that, as we now know with more detailed information, is that a lot of those, the bone injury was actually the cause of the symptom, and the meniscal tear was just a non-important standby. And then also you can see, however, that there is a fairly good association between subchondral bone injuries and meniscal tears, which is kind of what they were showing. Okay, so now this is on 7/12/11. Okay, now the patient developed locking, and this is the scan a couple of weeks after the first one. This is about a week after locking started.
Okay, so we have two more sagittals.
John, I think the prior slide showed locking also, which I find unusual.
No, the patient was not, the patient started locking a week after this study was done. See, locking started 1 week after the first study.
Okay.
I'm sorry, the way I worded that is confusing. I tried to clarify. So at this time, there was no locking. A week later.
If you look at MR, I would say maybe giving way or maybe catching or something, but pure locking, that doesn't look like that would be happening, but obviously the patient knows better than I do.
Well, at this point, it was not locking.
Okay.
Okay. Now, a week later, the patient started locking, and a week after that, they did an MR scan, and this is what the MR scan looks like now, a week after it started locking, which is about 2 weeks after the first MR.
So we have two more sagittals. On the right there, it looks like there's additional structure in that intercondylar notch. So I'd be concerned for a bucket handle tear displaced fragment. And then there's blunting of the free edge there.
And you can see that central portion of the free edge is now displaced.
Mm-hmm.
It's a displaced bucket handle tear we see there.
Yeah, but what do you see anteriorly?
I don't see a whole lot of meniscus there.
So where do you think that meniscus hit?
I think it displaced into the intercondylar notch.
Yeah, that's where the arrows are.
Yeah.
And the whole point here, the way I see it from the orthopedic standpoint, if the patient had been put in a immobilizer and crutches after the injury, it's conceivable that this patient might have healed without surgery.
I agree with you, John. And then there you can see that displaced bucket handle tear in the notch of the knee on the coronal image. So this was a peripheral tear, which involved the posterior horn and the body, and had a kind of a vertical component to it. It was kind of a complex peripheral tear. But what happened is, because they allowed trauma to continue to occur in the knee, it got the vertical tear completed all the way to the front, and then you got displacement of that central fragment. So as John was saying, that if you had decreased the amount of motion in the knee, allowing for the meniscus to heal first, since it was in a red zone, that maybe this would never have displaced. You wouldn't have gotten a bucket handle tear, and you might have gotten biologic healing. So
yeah, we a month or so in a knee immobilizer wouldn't hurt the patient, and conceivably you could get away without surgery.
So these peripheral tears, especially if they look like they're longitudinal like this, are increased risk for displacing if the patient's not properly managed.
So we see a complex tear on this coronal. It's obviously got an
There's a
oblique
complex tear right
peripheral
there.
component. Then
Yeah.
do we say unstable on our
No, I would just comment on what it is, and it'd be up to the orthopedic surgeon then to treat the patient appropriately. In this particular case, what probably would make sense to put an immobilizer to allow this to start healing so that you don't have this happen.
Okay.
But I think there are a lot of orthopedic surgeons that will get very angry at you if you start telling them how to treat the patients on a radiology report. So I would not do that.
And it's a conservative way, the way I was explaining the situation. So aggressive surgeons would have operated right from the get-go. Conservative surgeons would have treated it conservatively and then checked the need, rehab, etc. Down the road and see what happens. There's no harm done by immobilization and progressive movement.
Yeah, and if you're very worried, you can call the doctor up and talk to them about it. And if it's a non-orthopedic surgeon, and in this day and age, often orthopedic surgeons don't want to see the patients until after the MR. So the MRs are commonly ordered by non-orthopedic surgeons who aren't very sophisticated in their understanding of pathophysiology of the knee. So it doesn't hurt to call up on the phone and discuss it with them and make sure that the patient is properly managed.
Okay.
Okay, Elior, what do you think of this case?
We see, I think there's a irregularity of the posterior horn. I think
Right.
maybe there's a displaced fragment anteriorly.
Okay, and it looks like there's a fragment here, and this looks like that anterior, getting close to the anterior root attachment here. And then, and that's what this is. This is really kind of a bucket-handled tear, but it's really a displacement primarily of the posterior horn anteriorly rather than the body into the notch of the knee. And here's a patient who came in with locking. And here we can see that the entire posterior horn of the lateral meniscus has a peripheral tear and displaced anteriorly. That produces a big mass effect here anteriorly. And if you try to extend the knee, this keeps you from extending the knee because there's too much mass here in the frontal part of the knee and doesn't allow full extension. And one thing to remember is if people walk around with inability to extend the knee completely, there's a very high rate of developing degenerative disease. So that's not something you want someone to do.
And pretty rapid also. It can be within weeks.
Yeah, so it can be impressive. Okay, Jason.
All right, so we have axial T2,
Yes, it's actually a
T
PD.
PD of the knee at the level of the ACL, which appears disrupted.
Okay, so here you have a PCL there, you've got something here, and you've got something there. So this now you have three PCLs. Where did you get three from? You're only supposed to have one.
Well, possibly a bucket handle of
Okay, there's the
one
medial side. There's a sagittal. There you can see a sagittal through the medial side. And as we go through that medial meniscus, it looks
got
like the posterior one is
truncated
kind of
up
truncated
posterior.
there. And then that really looks very abnormal. So it really looks like, and then here, if we go here, we can actually see that there is a heavily degenerated bucket handle tear coming down here. So that's kind of two. So that's probably the, okay, that's probably the bucket handle tear. So what's this third one down here?
Is that the ACL?
Okay, and the other thing you can have a bucket handle tear and an ACL tear. Oops.
If you look at the effusion on one of the sagittal views,
Yeah,
that kind of reminds you of an ACL injury. The knee blows up quite a bit
right.
because of the bleeding.
Yeah. So here's a PCL, there's the bucket handle displaced fragment, and here's the ACL that should be going up and attaching up here on the lateral wall of the notch of the knee, and instead you've got fluid there. So you're right. This is a patient who has a
Yeah,
bucket handle tear, a torn inferior displaced ACL that will tear that we'll talk about later, and then the PCL back here.
and the large effusion up above.
And a large effusion that John was telling us up above. Right.
So
Okay.
you have to pay attention to effusions. Don't ignore them.
Right.
All right, so we have two coronals of the knee. Looking at the medial meniscus, it looks like there's blunting of that free edge and a displaced fragment.
Blunting of the body, right?
Sorry, yeah.
And then it looks like you've got a displaced fragment here. Okay, this is on 10.807, right there. On there, you can see that displaced bucket handle tear. Then the patient came back on 10.16.08, so a little bit over a year later, and this is what it looked like.
So the body free edge looks a little bit better now. So I would assume they had surgery in the interim.
Okay, and they also now have an anterior cruciate ligament graft,
Yeah.
so they had surgery. We don't see that displaced bucket handle fragment anymore, right?
Correct.
And the peripheral rim looks pretty normal. So that was a bucket handle repair, and the patient did well. So this is just an example. Here's kind of the bucket handle fragment. Now with bucket handle repair, they basically bring it back and suture it back into place. Okay. Elior, what do you think of this one?
I see a longitudinal defect in the posterior horn.
Well, I think we see a vertical here defect. If we had multiple cuts that saw that it went along the meniscus, then it would be longitudinal, in case, which is actually the case here. But at this point, we just see vertical signal intensity here at the junction of the posterior horn and body. And this is on the PD, this is on the T2.
Longitudinal would be a bit difficult to see on a sagittal view.
Yeah. So here's an axial view. What do you see here, Elior? And by the way, this is the larger, this is smaller, this is the medial side over here, and this you can see this is the medial meniscus. Okay, so what do you see on the axial images?
In the region of the posterior horn of the medial meniscus, I see, yeah, like this.
So here's that peripheral longitudinal tear. So you were right. But if we follow John and look at it in the axial images, we can actually see the longitudinal component of it right there. So this is a peripheral longitudinal tear. And this is one that could be at risk for continuing. And this is probably a precursor to a bucket handle tear. So I think these are, you really want these to heal and do whatever is necessary. Now, let's just say, for instance, that this patient had an ACL tear as well, acute ACL tear. What would you call this kind of a lesion if the patient also had an acute ACL tear?
I'm not sure.
Peripheral tears in the posterior horn of the medial meniscus in a patient that are acute like this, see how black the edges are?
Yeah.
In the setting of an acute ACL tear are called ramp tears, R-A-M-P. We'll talk about, I think we'll talk about them now, but if not, a little bit later. And the orthopedic surgeons, or at least a lot of orthopedic surgeons, really want to know about these. If they're going to go in and repair the ACL, put in a graft, they're also going to want to suture these to increase the likelihood that these will repair since they're already in there. So that's the peripheral longitudinal tear. And so instead of ACL tear, these are called ramp lesions. So let's talk a little bit about ramp tear. These are posterior longitudinal tears in the periphery of the medial meniscus. The lateral meniscus has different morphology that we'll talk about, so you don't get ramp tears on the lateral side. And they tend to involve the meniscocapsular ligament, the tibial ligament, and the red zone of the posterior horn. So there are.
And this, we're talking about the medial meniscus tear causing many ACL tears.
No, we're talking about at the time that you have an ACL tear, you give it a pivot shift mechanism of injury that we'll talk about with ACLs. The knee becomes unstable. And when you do that, there are shearing forces that primarily affect the periphery of the posterior horn of the medial meniscus. And it can cause a series that we're going to talk about right now of tears associated with the posterior horn and posterior meniscotibial attachments of the medial meniscus. And those are called ramp tears, and they're caused by the abnormal displacement that you get at the time of an anterior cruciate ligament tear. Thanks, John, to clarify that. And so here's one classification from Griff et al. In skeletal radiology, and they do a type 1 through 5 where you've got B's and 3A's and 3 and 4 A's and B's. Now, I'm going to go through these, but don't memorize it. I don't think it's important to actually use this classification, though you might go somewhere where an orthopedic surgeon wants you to classify it. A type 1 is a meniscocapsular ligament tear, which I will show in a minute. Type 2 is a partial superior tear. And both of these that involve the superior meniscal ligament attachment are considered stable and don't require surgical repair. The ones that involve the inferior peripheral attachment of the posterior horn are considered unstable, and it's recommended that those be repaired at the time that they do the graft placement. So if you have a partial inferior tear, meniscotibial ligament tear, again, that's going to the tibia inferiorly, a complete posterior horn tear, a complete meniscal junction tear, or what's called a double tear that I'll show in a minute. These are all unstable lesions, and it's recommended that the arthroscopists look at these and decide whether to repair these at the same time they put in a graft. So looking at the anatomy, this is a little cartoon showing the anatomy. Here's the posterior horn of the medial meniscus. Here's the meniscocapsular ligament. This is the meniscotibial ligament down here. This is the posterior capsule, which comes out here, peripherally here. And here's the tibia. And then here we can see that here's the superior area where you have the meniscocapsular ligament, the inferior area where you have the meniscotibial ligaments. And again, inferior injuries are considered unstable. An isolated superior injury can be a stable lesion. Here's that peripheral capsule, and here's the superior meniscocapsular ligament, and inferiorly here is the meniscotibial ligament. So the meniscotibial ligament you don't want torn. Okay, so type 1 ramp tears are tear this superior meniscocapsular ligament up here. There you can see it torn on an MR examination. Here's, and then back in through here, and this just shows it at arthroscopy where you can see fraying over here, but the tibial meniscal attachment looks like it's in pretty good shape, and so this would be a type 1 lesion or type 1 ramp tear, which would be stable. A type 2, here you can get a little bit of a tear of the superior posterior meniscus, but it extends down into the meniscocapsular ligament superiorly, but again, that would be considered a stable lesion just involving the superior periphery. Personally, I think all you need to do is call that there is a peripheral capsular tear here, compatible with a ramp lesion, and let the surgeons decide what its significance at the time of surgery. And then type 3A are these more inferior tears down here, this one involving the capsule and the meniscotibial ligament attachment here, and it's on the inferior side there. And again here, this is inferiorly showing the meniscotibial attachment being torn. This is at arthroscopy. And see, a lot of these can't always see real well. And then here again is a tear of the meniscocapsular ligaments here inferiorly, which would go along with a type 3B, which would be an unstable type tear. And the type 4s are the peripheral tears of the meniscus, going all the way through. Peripheral meniscus here, more central meniscus, but this would be a peripheral longitudinal, vertical and longitudinal tear involving the posterior horn. And here the tear is going along through here. Again, I would just call this a ramp tear. And then this would be a type B. In this particular case, you don't see a peripheral component of the meniscus. This is just a complete tear of the meniscotibial attachments back in this area. Again, I would just call it a ramp tear, where you see no longer connections between the meniscus and the peripheral capsule. And then a type 5, you can actually sometimes see double lines back here. And again, I think most radiologists will just look back here, look carefully at the periphery of the meniscus and its attachments, and just state whether you see a ramp tear or not. And then that tells the surgeon to take a very careful look in this area at the time of surgery to decide, depending upon what they think they should do, whether it needs to be stabilized by some sutures or not. So those are ramp tears. So if you see an acute ACL, the next thing you have to do is look at the periphery of the posterior horn of the medial meniscus. Okay, I don't know. Who did the last one? Anybody knows? Okay, Tayson, what do you think of this one?
All right, so it looks like we have a proton density coronal of the knee.
It's T1.
T1. It looks like there's a horizontal oblique signal within the the body of the medial meniscus,
Yeah, we're getting
reaching
close
the
to
tibial surface.
posterior horn and body junction right there.
Okay.
So you're right, there's something there. And that was a peripheral tear. This patient did not have an ACL tear, so I wouldn't call it a ramp tear.
Okay.
Okay, whoops. Giving you the answer. That's not
So we have a sagittal
fair.
of the lateral compartment there. There's a complex tear of the posterior horn of the meniscus.
Okay, well, we don't see a lot of displacement at this particular time, but it looks a little bit like we're concerned about that, whether it went onto a bucket handle tear. This is on the lateral side. This was on 10-3. So then what they decided to do is a partial meniscectomy. And so here we can see 8 months later, they did a partial meniscectomy and removed that central fragment. So this is back in 2003, 2004. Nowadays, people would try to repair this if they could. All right. It just shows one treatment. So, Elior, what is the long-term outcome after arthroscopic repair versus arthroscopic partial meniscectomy for traumatic meniscal tears? And this was from way back in 2010, American Journal of Sports Medicine. So what are these two surgeries, what were the differences in long-term outcomes?
So what we've said so far in these lectures, I think there'd be better outcomes with the repairs versus the meniscectomy.
So this was a level 3 cohort study. They had 81 patients, 42 with repairs, 39 with meniscectomies. And what they found was if they followed them up or by x-rays, on their repair patients, 80% or 81% had no degenerative disease with an average of a 9-year follow-up, whereas 40%, only 40% had no degenerative disease after partial meniscectomy. If you look at return to pre-injury levels of athletic activity, almost 100% returned to pre-levels with the repair, only 50% returned to pre-levels with a partial meniscectomy. Also, they found that they had much better success with ACL reconstruction if you did a partial meniscectomy. And you also, the ACL reconstruction also increased the likelihood that your repair of the meniscus would heal. So, there's a lot of things you could be concerned about this. Were these randomized? Were these the same group of patients? Were the repaired group actually less injured than the other repair group? So there's a lot you can discuss with, but there are other papers now that have confirmed these findings. So certainly in the professional athlete, now they always try to do a repair rather than a partial meniscectomy if possible. But you have to see what you see when you get in there. And as John's going to tell us in a minute, the MR scan can be helpful, but you don't really know whether you can repair something until you get in arthroscopically. Right, John?
That's true. I'm not sure I would buy the statistics because picking patients is difficult to do, and guess it's a guesswork in some ways. For instance, you have 80.8%. 80.8%. I don't know how they get that 0.1%, but and 40% meniscectomy. It doesn't say partial meniscectomy; it says meniscectomy.
Yeah,
Now,
partial meniscectomy. That's my term. It should say partial meniscectomy.
yeah, I think that I would be a little skeptical about the great results that you get from repair.
Okay. So we'll see some other papers as well here.
I'm sure we will.
Yeah. So their impression was arthroscopic meniscal repair offers significantly improved results for isolated traumatic meniscal tears, and generally, especially for professional athletes, this is really the kind of the rule in this day and age. So the indications for meniscal repair, if it's acute traumatic tear, certainly in young athletes, you should try meniscal repair. If they're peripheral tears in the red zone, either let them heal, or if these are a lot of athletes and they really want to get back into athletic activity rapidly, they will go in and do a repair procedure, suture it in place. And the feeling is that you're much more likely to get a good result, especially if they're going to continue their athletic activity. If they have sharp fragment margins, that means that you have a non-degenerative tear and is more likely to heal. And if you have normal signal intensity within the meniscus. So this is another paper in 2019, overall impressions of the role of partial meniscectomy for treatment of meniscal tears in 2019. Partial meniscectomy is not indicated for the treatment of stable degenerative tears of the knee. We've already said that many times. With acute tears, meniscal repair is a preferred technique. And why don't I have the...
Well, you also have to think about where the repair is done, what part of the meniscus. If it's a red zone, you're going to have much better results than if it's middle third of the meniscus. So if you choose the red zone on patients, you're going to have close to 90% results. But if you choose the middle third,
not so good.
You're not going to have the results that we're talking about here.
Yeah, about 22%.
In fact, the results are not going to be that good, not even close.
Good, yep. So I'd like to talk a little bit about the meniscal root attachments, both on the medial and the lateral side. And if we look, these are important because, one of the main functions of the meniscus is to stabilize the knee. And therefore, you have to have a good firm attachment of the meniscus to the tibia to do that. On the medial side, if this is the femoral condyle, then the meniscus acts like little brake stops, like you might have in a car if you're going to park your car. And if you have a good meniscotibial attachment here, that's going to produce a stable positioning of the femoral condyle. But if you have a ramp tear, like we see here, then what's going to happen if you put pressure by the femoral condyle against that posterior horn of the meniscus will not be stable. It will displace posteriorly, and that leads to more instability of the joint space. This is called the break stop function of the posterior horn of the meniscus. So, and one way to look at this is a thing called the uncovered medial meniscal sign, published 2018 in AJR. Normally, the margin of the posterior horn of the medial meniscus should be anterior to the peripheral rim of the posterior aspect of the medial tibial plateau. We're on the medial side right now. If it goes beyond that posterior rim, then that's abnormal, and that's an indication that you've got a peripheral meniscal capsular tear, and you've lost the break stop function. Okay. Robert, are you next? There we go.
So we have a coronal of the knee here. Looking at the medial meniscus, looks like there's increased signal.
Signal there.
Yeah, but
what do you think about?
I think the attachment looks okay.
Yeah.
I think I can follow it all the way.
So these are the posterior root attachments of the medial meniscus and the lateral meniscus. And I like to talk about the posterior root attachments because many years ago, when I was in Santa Barbara, Rick Ryu and I, who was an orthopedic surgeon in Santa Barbara, wrote a paper that we tried to publish on visualizing posterior root tears on MRI. And we sent it into a couple of journals. One of them was a radiology journal. The radiology journal actually had an orthopedic surgeon who helped review the paper, and it was rejected because the orthopedic surgeon said that menisci just don't tear at the posterior root attachment. That was in the early 1990s. Now, a big topic in the last 2 decades has been posterior root tears. So we'll talk about those right now. So here, on every MR of the knee, I like to look at the coronal images to look at the root attachments. If you don't force yourself to do that, you can occasionally miss important root tears. So just always make sure whenever you look at a knee that you look at these posterior root attachments on the coronal images. I also like to look at the anterior root attachments, but they're not nearly as important because they're not torn as much. Here's the anterior root attachment of the lateral meniscus in the coronal plane, and here's the anterior root attachment of the medial meniscus in the coronal plane. Now, another structure that we're going to talk a little bit about is this, which is the transverse ligament, the anterior transverse ligament. You can see that you can get a little separation here between the transverse ligament that goes from the anterior horn of the lateral meniscus to the anterior horn of the medial meniscus. We never saw this by old-fashioned arthrography. So when we first started doing an MR scan, sagittal images would show some increased signal intensity between that anterior root attachment, which I'm going to show a little bit later, and the meniscus, and then this transverse ligament. So one day when we were just starting to do MR of the knee at Cedars, we looked at a player for the Raiders, who was their wide receiver when the Raiders were still in LA. And then we called a tear of the anterior horn of the lateral meniscus because he had knee pain on Wednesday. By Friday, he was feeling okay. So they went ahead and let him play on Sunday, despite the fact that we said that there was a meniscal tear, and he broke the NFL record for most number of yards from a wide receiver in a single game. So we decided to go back and go back to the drawing board, so to say, and then we looked in anatomy text outside of radiology, and there was this transverse ligament in the anatomy text. And then we went back and looked at things, and this is very common. And if you're not careful in the sagittal images, you can make that mistake. Though almost everybody in radiology now is just used to it, so they don't even notice it anymore. But it was a little bit embarrassing back the first time we ever saw it. So we'll see that again. Let's see. Elior, what do you think here?
So we've got coronals, PD and PD fat sat on the right.
So this is a 3 Tesla low field scanner. This is a T1 and this is a STIR.
Okay. I'm seeing discontinuity of maybe the posterior horn of the lateral meniscus.
Yeah, that's an artifact of the positioning here. The lateral meniscus is very C-shaped, so its actual root attachment to the bone is the next cut anterior to this, whereas the medial meniscus is more comma-shaped, and its bone attachment is a little bit more posterior than the lateral. I just want to look here. So this is actually, point this out as a normal posterior root attachment of the medial meniscus. Okay? And if we go to the sagittal images, you can follow that posterior, the black signal from the posterior horn of the medial meniscus all the way till you get the cortex of the bone. And that's basically what our paper was about that didn't get published. Okay, and so this is in 11/10/2003. Okay, now the patient came back with another injury, and now we're May 12th, 2005. Oh, forget it. I gave you the answer. So what do you think?
I think there's a posterior root injury.
Okay, so here we can see that you don't have black signal going all the way to the bone, and you've got a lot of bone marrow edema within the posterior, near the root attachment of the on the posterior medial tibial plateau. So this is what an acute avulsion looks like of the root. You get a tear of the root, and you often will get this bone edema where it kind of avulses part of the bone there. And if you go to the sagittal images, and you try to follow that black signal of the posterior horn, you get to a point where it's gone, but you're not all the way to the bone yet. So this is a posterior root attachment. And then this is what it looks like arthroscopically. Here's the femoral condyle up here at the top. Here's the meniscus. There's the free edge of the body. Here's the tibial plateau. We're going to go back in the back, and this is actually, you can see this is the meniscus, and it's bleeding here because it's been ripped off its tibial attachment, and this is that root attachment tear. And if you look arthroscopically, here's what it looks like. You go back to that posterior, there's the tear, put the probe in, and you'll see it's very unstable. That should be firmly attached to the bone so that it gives a good break stop and stabilizes that medial side, and it's completely loose. So this meniscus is no longer going to function properly to stabilize the medial side of the knee because you have a root attachment. Unfortunately, I didn't have this arthroscopy at the time we tried to publish that first paper. And now many people have published on this, and we know that root tears are associated with poor outcomes.
I think one of the problems with root tears is they're difficult to repair. You have to drill from the anterior aspect of the tibia posteriorly to put sutures in, and there are several different techniques like everything else in orthopedics. But there are 5 different types of root tears, and some are described in Campbell's, but I don't. There are some that are partial root tears, which you leave alone. Then there are complete radial tears, but not displaced, and
Okay.
bucket handled tears, as well as oblique tears into root attachment and
Okay.
root avulsion. fracture. So it depends on what you have in terms of the injury as to what kind of results you get.
Okay.
I don't know whether the publishing here explains the 5 different uh, types of root tears. You also get ACL tears along with these as well.
That's right. Because this can be a form of ramp tear.
But you have to be um, doing a lot of arthroscopies and know what you're doing to deal with this particular injury. An
Good.
everyday surgeon, I don't think has the ability to fix these.
Okay. Elior, what do you think of this case?
Okay, so we have coronal, is it PD on the left and PD, that's it on the
Yeah.
right?
It's actually a T1 on the left and a stir on the right, but that's not important. Don't worry about it.
I'm seeing discontinuity of the medial posterior root.
Okay. So this root, so you can see that it's torn off. So here we have another root tear. Notice here you got fat going with the posterior horn. That's bright on the T1, black on the stir image, and this is actually a bony avulsion. So you can see this has been, the bone has been avulsed off, and you can see then that's why you sometimes get edema within the bone there. This actually makes the repair more likely to be successful because you can bring that back, and bone heals very nicely to bone, but soft tissues don't heal all that nicely. The soft
That's the
tissues.
type 5.
What? That's 5. Okay, that's the top 5. So then we can see that. If you go to the sagittal images, there's that posterior horn, and then we should see it right here because we're not really to the point where it should be placed there, but it's no longer there. So that's a root avulsion. The other thing you look for with root avulsions is you look through the mid-body coronal images to see if you have extrusion of the body, which we'll talk about in further lectures, the significance of that. So this would be a root avulsion. Okay. Jason.
All right, so we have 2 coronal images of the knee for rule out meniscal tear, history of trauma. Is there an avulsion of the posterior root of the medial meniscus
Yeah,
there?
right here.
And
And
maybe
you can see it's taking a little lump of bone out here.
yeah.
There's that little fat that's going with it. So good. Here's another, a bony avulsion of the posterior root. And what do we see here? Let me see this. It's the same patient.
Is that fragment behind the PCL our
I can hear.
avulsed fragment right there?
And that's their avulsed fragment. Yep. And this is a patient who had a ACL graft.
This is a patient that needed a surgeon that practices on a daily basis.
Right. Robert.
So we have 2 coronals in a 64-year-old female with post-traumatic knee pain. Medially, it looks like there's probably a root tear there. And then laterally, there's some vertical signal as well.
We're just partial volume in the edge of it. Again, the
I see.
the root attachment of the lateral meniscus is going to be 1 or 2 cuts more anterior because it's very C-shaped, which you can look at when you start looking at knees again. Look at those, the coronal plane at the different root attachments.
Sure.
Okay, so now this is a couple of years later, and this is what it looked like.
That's some artifact there, so maybe they try to repair the.
Right. So this is a root repair. In this particular case, there's a lot of metal artifact where they try to repair it. There, as John says, there are multiple different ways. Here we can see another type of root tear here. This is posterior medial again, root avulsion. And then this is on 12/1909. This is a month or two later. What we're seeing here is in that particular area. They've done a repair. Here's a bone tunnel that's going here. Here you can see the bone tunnel coming down through here. So they sutured around that posterior root, brought it back into the bone, brought the suture anchor to the periphery here, and put a button out here to stabilize that posterior horn. So this is another type of root avulsion repair.
That looks a good repair.
Yeah, I think this patient did well. So what is the effectiveness of root repairs? They looked at a meta-analysis of 9 studies, 355 patients. They found that the repair group had less arthritic changes than the non-repaired group. And they also found that the repair was more cost-effective because people who didn't have the roots repair went on to total knee replacements at an earlier stage than those who had the root repair, and therefore ended up being actually more costly. So the root repairs are cost-effective according to this analysis in the American Journal of Sports Medicine. Now, we've kind of talked about one kind of way to describe tears, which is mostly kind of an old-fashioned kind of technique. I think people are trying to modernize it. There is a description classification by the International Society of Knee Surgery here, where they basically said there are 10 different things that you need to describe in a meniscal tear. I don't use this. This is more for use if you're doing research projects. They look at tear depth with partial or complete, the location, both in the circumferential as well as longitudinal location, posterior anterior locations. As we go to central, the morphology of the tear shape, and when it goes to the free edge, the quality of the surrounding tissues, is it black, non-degenerative, white, very degenerative, or in between, the length of the tear, and then if they've had prior partial meniscectomies, the amount of meniscus that was removed. And I could go through all these, but I'm not going through. They're all things to kind of think about, and there are ways to quantify them if you're doing research. But most people really don't go into this kind of detail when they describe a tear on an MRI examination, but you may deal with those if they want you to.
Campbell's doesn't use it.
Yeah. So this is where that was published. So why don't we stop here, and we will continue talking about meniscal disease on Thursday. Okay. Thanks.
Well, have a good day off, everybody, and
Thank you, John.
All right.
careful driving.
Did you? Thank you.